Welcome back to AI on AI, where we unpack cutting-edge models by putting technologists and business leaders at the same table. Today, we're diving into generative medical event models trained on longitudinal health records and what it means to simulate patient timelines at scale.
Thanks for having me. What's striking here is we're seeing a decoder-only transformer trained over more than 100 billion structured medical events, learning to auto-regress the next diagnosis, lab, medication, procedure, or time step, and then using Monte Carlo generations to answer a huge range of clinical questions without task-specific fine-tuning.
And the kicker is the scaling law story. The team followed isoflop contours to choose compute-optimal model sizes and token budgets, fitting parabolas to loss versus parameters under fixed compute, and then extracting power law exponents. Alpha and beta both around 0.51-ish, suggesting proportional growth in parameters and tokens is optimal for this domain.
For business leaders, this isn't just technical elegance. The models match or outperform task-specific baselines on a majority of 78 evaluations, from disease prognosis to readmission risk and care operations, which implies fewer bespoke models to build and maintain, simplifying your analytics portfolio while broadening applicability.
I'm going to add the governance lens. These are de-identified, multi-institutional records, but completeness varies across systems and time, so any deployment must keep a live handle on data drift, calibration drift, and subgroup fairness. The paper's subgroup AUCs looked reasonably stable, but reasonably is not done, and continuous measurement is critical.
Technically, I'm intrigued by how they tokenize continuous labs into quantile buckets per LOINC unit pair. It's token efficient and training stable, but it also quantizes clinical signals, so downstream numerics, like predicting A1C in 3 months, carry expected noise. It's a trade-off that could be mitigated with continuous tokenization or hybrid heads later.
Let's unpack the generative inference loop, because it's the heart of the value. How does simulating multiple patient futures become a single actionable prediction at the bedside? Think weather ensembles. You run, say, 40 to 80 stochastic timelines conditioned on the patient's past and compute P, event within T, as the fraction of trajectories where the event occurs within T, adjusted for censoring if a trajectory doesn't reach T. That gives you calibrated probabilities, time to event distributions, or even sets of likely events for a given encounter.
Clinically, that yields a ranked differential diagnosis early, say hepatopancreatobiliary diseases, where the model progressively pushes the correct diagnosis to the top as more evidence accumulates, and it does so weeks before definitive labels in many cases, which is useful for triage or prompting earlier workup.
And because they model time explicitly with passage of time tokens, it naturally handles gaps, out-of-hospital intervals, and irregular event spacing, an underrated necessity in EHRs where silence often means something.
From a strategy perspective, imagine an integrated delivery network using this to orchestrate capacity. The study's length of stay predictions beat strong baselines on admissions under 2 weeks, and the 30-day readmission AUC around the upper 0.7s tells me we can meaningfully rank discharge risk and queue transitional care resources with better yield.
We'll come back to operations, but first the scaling laws. Many leaders ask, how big is big enough? And what's the right token-to-parameter ratio in healthcare? The analysis suggests the compute-optimal token-to-parameter ratio is about 1,000 to 1, dramatically higher than typical language models, likely because medical events are far denser in causal signal per token. They trained up to roughly 1 billion parameters with more than 1 trillion tokens, and loss declined smoothly as predicted by those power laws.
Importantly, they checked whether lower loss actually translates into better clinical metrics. In shockingly clean sigmoids, AUCs for readmission, CKD progression, and single encounter predictions all improved as cross-entropy fell, so minimizing pre-training loss is a meaningful proxy for downstream clinical utility here.
One detail I appreciate is the sequence packing during training. They densely fill the 8K token context window and separate patient sequences with a boundary token, which materially improves throughput without harming the next event objective. Classic systems win that yields better compute efficiency.
But note the context constraint. Many patients exceed 8K tokens, so left truncation is used at inference. That's acceptable because recency matters clinically, but it underscores the value of longer context models and retrieval over compressed representations for equity. Longitudinally complex patients often are the ones we must not truncate away.
On ROI heuristics, I like to ask, can a single foundation model replace 5 niche models and still make the top decile predictions better? If yes, even with a small uplift, that's a compelling lifecycle cost argument, especially when regulatory validation, maintenance, and MLOps overheads multiply with each new model.
Let's get concrete. In disease-specific outcomes for diabetes and hypertension, where did this model surprise you?
In diabetes cohorts, at the moment of initiating therapy, it predicted 3-year ASCVD risk and 1-year CKD progression as well as or better than tailored baselines, and it predicted short-horizon A1C targets with decent MAE despite the quantized lab representation. Honestly, I expected a bigger gap versus supervised transformers tuned to that single task.
Hypertension showed similar patterns, steady gains with scale, with the largest model matching or beating baselines on about half the tasks. Interestingly, hyperlipidemia cohorts lagged. Still strong absolute AUCs, but a consistent few points behind task-specific models, which suggests some cohort-specific signal leakage the supervised baselines exploit. Maybe text cues or nuanced lipid panel trends not fully captured by quantiles.
Or it's the vocabulary. Only the top 1,000 numeric labs and 1,500 procedures are tokenized. That covers most events, but tail features matter for lipidology. Rare fractions, apolipoproteins, specialty panels. This is where bigger vocab or mixed discrete continuous heads would help.
Cautionary flag. When a foundation model underperforms in just one disease family, you risk someone drawing the wrong conclusion. The model is biased against my specialty, so run specialty-specific calibration curves, and if needed, deploy specialty-tuned heads as policy, not as an exception you stumble into.
I'll translate that. Go live with a modular strategy, system-wide zero-shot deployments for broad coverage, then targeted lightweight fine-tunes or adapters for service lines with measurable gaps. That keeps governance simple and improves adoption because clinicians see uplift where they care most.
I want to touch the flight simulator for patient journeys analogy. The paper shows encounter-level generation, predicting what labs, meds, and procedures will appear in a given encounter. How good is it really? Precision recall curves were strong across outpatient, ED, and inpatient settings. Compared to naive lookbacks, the model recalls new, previously unseen events while filtering out stale noise, which is exactly what you want. PR AUCs improve monotonically with scale, notably for labs and procedures in inpatient and ED contexts.
That's actionable for clinical decision support. Imagine opening an ED encounter and getting, with calibrated probabilities, the tests and interventions most likely to be ordered or needed. Useful for supply staging, phlebotomy routing, and even prompting best practice alerts without being annoying.
And the calibration story on encounter counts is reassuring. Expected calibration error dropped with scale across office, ED, and inpatient visit counts. This matters because utilization forecasts drive staffing and bed planning. Poorly calibrated probabilities are worse than no model because they misallocate finite resources.
We piloted a similar concept at one system, forecasting inpatient admissions and LOS by service line, then aligning nurse float pools and med-surg bed turnover. Over 2 quarters, boarding time shrank in the low teens percentage-wise. A soft but systemic improvement derived from better probabilistic forecasts rather than a single Big Bang intervention.
But Goodhart's law lurks. Optimize solely on readmission AUC, and you may over-index interventions toward patients who present more frequently, potentially exacerbating disparities. That's why subgroup fairness dashboards and reweighting strategies are part of go-live criteria.
Let's tackle the incident disease tasks. These were extremely imbalanced, and the model didn't top baselines on AUC across the board, yet it outperformed on PR-AUC. Help us reconcile that. Classic evaluation nuance. When prevalence is under 1.5%, PR-AUC is the more informative metric. The model's PR wins suggest better precision at top risk, i.e. the top risk decile is cleaner, which is exactly what population health needs for constrained outreach capacity. AUC punishes you for threshold-insensitive ranking on negatives and can mask that top decile quality.
In practice, a care management team has limited slots. If your model finds more true positives in the same outreach cohort, you're winning, even if the ROC curve lags by a point, because the operational objective is precision at K, not theoretical discrimination across the entire score range.
The authors also showed test time compute scaling. More simulations per patient, N, lifted performance substantially, especially in these low prevalence tasks, with clear gains up to around 64 trajectories. That's a compelling knob to turn when latency budgets allow.
Which raises the trade-off. Do you spend compute at training or at inference? The bitter lesson says, use more compute, but budget and latency say otherwise. Strategically, I'd run a policy. Short N for bedside tools with tight latency, ED triage. Long N for batch population scans or nightly registries.
And document it in model cards. Clinicians deserve to know that a morning batch registry used 128 simulations, while the bedside alert used 16. The capabilities are not identical, and transparency avoids trust erosion.
There's a contrarian view I've heard. We're over-rotating to multimodal when the real bottleneck is temporal and vocabulary design. Agree or disagree? I agree more than not. Adding notes or images helps, but the order of magnitude gains here came from getting time right, explicit time tokens, censoring aware probabilities, and choosing a medically grounded vocabulary that collapses code sets into token-efficient units. Multimodal should come next, not first.
Strongly agree. Garbage temporal modeling plus slick images is a lipstick on a pig situation. I'd first push context length, retrieval over long histories, and numeric tokenization that preserves extremes before I fuse radiology.
I'll dissent a bit. There are diagnoses where notes carry first signal features, like rheumatology and psychiatry. For those, multimodal fusion could close the gap where structured codes lag, especially early in the diagnostic odyssey.
Nuance accepted. Sequence design first, but roadmap multimodal, where the specialty's ground truth is inherently unstructured, and ensure consent pathways and de-identification withstand scrutiny because text is harder to sanitize.
Let's examine differential diagnosis, a favorite among clinicians. What stands out?
Two things. First, the model flags a rising fraction of true cases weeks before the index diagnosis date in several hepatobiliary cancers and chronic liver diseases. Second, within a cohort of similar presentations, it ranks the correct diagnosis higher over time, showing it learns discriminative patterns, not just prevalence priors.
And compared to task-specific supervised models trained across broader patient pools, the generative model's AUC ramps as you approach the diagnosis date, which suggests it tracks the patient's path-dependent evidence. It's leveraging sequence structure better than bag of words.
From an engineering standpoint, this creates a dynamic, quantitative differential that can be surfaced in workflow as watchful waiting with signal rather than binary alerts. Richer UX for clinicians and lower alert fatigue.
Business-wise, early flagging in chronic liver disease can redirect patients into surveillance pathways sooner, which correlates with improved outcomes. Even a few percentage points increase in early-stage detection can produce large downstream reductions in high acuity utilization over time.
However, put guardrails on early oncology flags. You must accompany them with explainability artifacts, e.g., which recent labs, procedures, or time patterns contributed to risk, and a do not alert if prior diagnostic plan exists logic to avoid duplicative workups.
Let's pivot to operations forecasting, encounter counts and low-S. What's the practical value beyond dashboards?
Planning is power. If you can forecast next year outpatient load per patient with lower MAE than traditional regressors, you can right-size panel management and preempt access bottlenecks. On LOS, even a day fraction improvement in prediction error across short stays can materially improve discharge planning cadence, reducing weekend bottlenecks and ED boarding.
Technically, I like the approach of predicting the encounter end token and aggregating the time deltas across simulations. It's a simple, consistent way to leverage the same generative mechanism for both clinical and operational targets. One engine, many outputs.
Also worth noting, they achieved better readmission discrimination than the strongest supervised baseline. Not a moonshot, but the area under the curve improvement is non-trivial when multiplied across thousands of discharges. Rank ordering is foundational to case management prioritization.
And the fairness picture for readmission was fairly flat across age, race, and sex strata, based on reported CIs. But again, flat doesn't absolve. We need impact assessments. Are interventions triggered equally for equally risky patients across strata? That's a deployment question, not just a model question.
Before we go deep into governance, give us a crisp technical deep dive. The isoflop method they used. Why should tech leaders care? Sure, training at 4 fixed compute budgets. They sweep model sizes and token counts, fit a parabola to loss versus log parameters along each isoflop, and pick the minima. Then they regress those minima against log compute to extract alpha and beta. If alpha beta 0.51, it means your optimal frontier grows both parameters and tokens proportionally, not one faster than the other. So you avoid overfitting large models on too few tokens or underfitting small models on too many tokens.
And the domain-specific twist is the 1001 token-to-parameter sweet spot. If you undershoot tokens, you burn compute on memorizing idiosyncrasies. If you overshoot, you waste passes on noisy sequences. This method tunes you into the economically efficient training plan, hugely relevant for budgeting GPU hours in healthcare IT.
For CIOs, this is a procurement lever. Demand from vendors a justification of their training point on the compute optimal frontier. If they trained a whale on thin data, you're paying storage and inference taxes without commensurate generalization.
Also ask vendors how they validated that reduced pre-training loss corresponded to real clinical task gains. What we saw were tidy sigmoids, but I'd want that correlation in my datasets too. Replication is a governance requirement, not a nice-to-have.
Let's talk tokenization choices. Quantile bins for labs, fragmented ICD codes into hierarchical tokens, ATC splits for meds, strengths, and gaps.
Strengths. It compresses a huge state space into 7K tokens, allows the model to learn relationships across code hierarchies, and keeps training stable. Gaps. You lose numeric tails and exact dose frequency details. Those tails can be clinically decisive. Severe hyponatremia lives in the extremes, not in the median.
Future directions include continuous tokenization schemes, learned numeric embeddings over ranges, or dual-head architectures where the decoder emits both a discrete event and a parameterized continuous value. That would close the loop on lab regression noise without exploding vocabulary size.
From a clinical perspective, the current approach still captured enough richness to beat baselines on single-encounter lab predictions in ED and inpatient settings, but I'd welcome numeric-sensitive upgrades for endocrine and lipid clinics where, as we said, narrow deltas matter.
And any extension must be accompanied by unit normalization audits. Numeric mishandling is a known source of silent harm. MG versus mol per L is a classic pitfall, so DevOps needs a hard validation suite on numeric pipelines.
The paper notes that performance climbed with more test time simulations. What are the deployment implications? It's a new axis of capability. Raising N reduces Monte Carlo variance and coarseness of probability estimates. Because timeline probabilities aggregate across trajectories, increasing N increases expressive resolution. Not just smoothing noise, but it's linear in latency, so profile it carefully.
Pragmatically, create service classes, low-latency endpoints with N16 to 32 for interactive use, and high-fidelity batch jobs with N64 to 128 for registries or weekly risk reviews. Instrument SLOs and fail gracefully to cached cohorts if compute spikes.
Business hint. Tie service classes to care management workflows. If community health workers operate Tuesdays and Thursdays, run high-end batches Monday night. If the ED needs rapid triage, accept lower N but feed queues with frequent refresh. This is operations-aware AI.
And never forget explainability. With multiple trajectories, you can surface exemplar futures. In 60% of simulations, labs trend X, then diagnosis Y. That kind of narrative beats Shapley values for clinician trust.
Another technical thread, left truncation and retrieval. With many patients exceeding context length, what's the right way forward?
3 options. Extend context with efficient attention, add retrieval to pull salient historical snippets, or pre-compress long histories into patient embeddings updated incrementally. I favor a hybrid. Retrieve structured salient chunks, e.g. previous strokes, transplant history, and maintain a rolling compressed state as prefix.
Agreed. And retrieval policies should be learned. The model can be trained to ask which past events help predict the next event, and fetch those on demand. You then avoid paying quadratic attention costs over thousands of irrelevant tokens.
Clinically, prior rare events like transplant or sickle cell crises are high signal and must always be in view. Retrieval makes that deterministic rather than hoping the oldest tokens survive truncation.
Whatever you do, log retrieval decisions. Auditing which past data was pulled is critical for traceability and error analysis when outcomes are contested.
Let's zoom out. What are 3 concrete business use cases you'd greenlight now and why?
First, system-wide risk stratification for acute on chronic events like CHF or COPD exacerbations. The model beat baselines across most of those, so a narrow outreach program targeting the top risk decile can reduce ED visits by high single digits percentage-wise over a couple quarters. Second, discharge planning support combining LOS forecasting with 30-day readmission risk to orchestrate home health and follow-up. Third, clinic panel management forecasting 1-year encounter counts to preempt access bottlenecks and smooth scheduling.
I'd add early differential diagnosis nudges for hepatobiliary and rheumatology pathways. Even a week's earlier suspicion can redirect imaging and labs, accelerating time to treatment, and single encounter predictions in ED could inform default order sets, turning best practice advisories from static to context dependent.
And from systems, nightly registries with high-end ensembles for incident disease like dementia or CHF onset. Not perfect AUCs, but strong PRAUC at the top risk band. Exactly what a limited outreach team needs.
Pair each with governance. Consent policies for de-identified to identified transitions, fairness dashboards, and clear stop-loss mechanisms. If calibration drifts or subgroup gaps widen, rollback is automatic. That's how you scale responsibly.
Now a tricky area, counterfactuals. Today's model simulates likely futures, but decision makers want, what if we change therapy now? How do we get there? You need objectives that penalize counterfactual inconsistency and possibly treatment effect heads layered on top. Pre-training teaches the data-generating process, but policy questions require explicit causal or semi-causal modeling. Think causal regularizers or synthetic interventions during fine-tuning to teach the model not to conflate association with effect.
Or hybridize. Use the generative model to define rich patient states and feed a separate treatment effect estimator, e.g. uplift modeling, trained with causal adjustments. That's deployable sooner and keeps generative pre-training stable.
Clinically, even counterfactual plausibility checks, like metformin initiation reduces A1C in 70% of similar trajectories, provide directional guidance for shared decision-making if framed properly, not as deterministic promises.
But regulatory posture matters. Counterfactuals used for patient-level guidance quickly enter validation-heavy territory. Start with population-level scenario planning before going bedside.
Let's talk about data quality and missingness. The study notes time tokens help the model read the gaps, but when is that not enough?
When events are systematically missing in certain settings, say outside care or unlinked labs, time tokens just encode silence, not absence of disease. For those, you need utilization filters as they used, conformance checks, and perhaps confidence-adjusted outputs that downweight predictions under sparse observation regimes.
The model can learn patterns of missingness if they are stable, but portability between health systems requires missingness-robust training and evaluation. Otherwise, your inferences are too tightly coupled to idiosyncratic documentation patterns.
A practical trick is to omit a calibration confidence. If the context includes few recent encounters or sparse labs, present a low confidence flag so users interpret scores correctly and governance teams can track how often low confidence predictions drive actions.
And for fairness, audit missingness by subgroup. If certain communities have sparser records, calibrate per subgroup, or provide adjusted thresholds to avoid systematic underservice or overflagging.
The study compared against 3 baseline families: linear logistic, gradient-boosted trees, and supervised transformers. What's the takeaway? Gradient-boosted trees were consistently strong and even beat supervised transformers in several settings. Structured data remains their playground, but the foundation model still matched or surpassed the best baseline on most tasks with zero-shot simulation, which is the whole point. One model serving many tasks with good performance.
And the supervised transformer baseline used the same architecture as a mid-sized model, but without pre-training, it didn't generalize as well. Pre-training on billions of medical events is not a luxury. It's where the long-range temporal understanding comes from.
This helps business tooling. Reduce your model zoo. If a generalist model gives you 90 to 95% of the best bespoke model's performance across dozens of tasks and beats them in many, you simplify compliance, MLOps, and change control. That reduction in cognitive and operational overhead is itself value.
However, maintain a surgical fine-tune pathway. Certain specialties will demand it, and you should offer it with guardrails and post-tune revalidation on subgroup metrics.
A quick quote break. All models are wrong, but some are useful, said Box. In healthcare, useful often means calibrated, fair, and interventionable. Did this work check those boxes?
On calibration, yes, encounter count calibration plots looked good and improved with scale. On fairness, subgroup AUCs for selected tasks were reported and fairly tight. Interventionability is supported through the simulation interface, probabilities, timelines, and ranks you can act on.
I'd add, fairness beyond AUC, calibration by subgroup, and intervention impact parity remains to be done prospectively. That's the next chapter.
What about the streetlight effect? We optimize what we can measure. Are we missing anything?
Patient-reported outcomes, social drivers, and genomic variants are underrepresented. Many conditions ride on those signals. Adding them could open new use cases, e.g., personalized care for multimorbidity, and reduce blind spots.
Also, censoring aware metrics. While they produce time-to-event distributions, many evaluations were binary within horizons. Survival-aware evaluation would align even better with the model's capabilities.
And context length again. Some of the sag in performance for certain cohorts is likely due to truncation. Retrieval and longer contexts should be an immediate roadmap item.
Risk management time. If a health system wants to deploy this, what must be in the playbook?
3 pillars. 1. Data governance. Data lineage, de-identification audits, unit normalization, code mapping validation. 2. Model governance. Pre-deployment replication on local data, calibration tuning, subgroup audits, service classes with SLOs. 3. Human factors, co-design with clinicians, progressive disclosure of explanations, and careful alert thresholds to avoid fatigue, plus continuous monitoring with rollback triggers.
Add contracting hygiene, demand access to evaluations, model cards, and the ability to fine-tune in your environment. Also, tie payment milestones to prospective utility metrics, e.g. precision at K in targeted outreach, not just retrospective AUCs.
Operationally, budget inference compute wisely, use batch where possible, and cache recurring cohorts. Profile latency across service lines. Invest in a feature store for tokenized streams and a robust scheduler that aligns with clinical rhythms.
And measure the loss-to-outcome curve locally. Verify that your pre-training loss and downstream AUCs move together during any fine-tuning. That's your early warning signal for overfitting or degraded generalization. Okay, let's inject a non-obvious insight. What's a systemic bottleneck most people are overlooking?
Honestly, the bottleneck is interface friction, not accuracy. If you can't place probabilistic timelines into clinician and operations workflows at the right granularity, visit level for ED, panel level for population health, you won't capture value. Spend as much engineering on UX and orchestration as on models.
I'll double down. Value gets realized in handoffs. An excellent risk score without a staffed escalation pathway is just a number. Design end-to-end pathways with service-level agreements before you launch models.
And measure unintended workload. If a model creates more review tasks than a team can handle, you may paradoxically increase delays. Monitor operational burden as a first-class metric.
Clinically suggested next best actions with time-aware reasoning, order X now, reassess Y in 3 days, can reduce friction dramatically. Timelines are the kernel, but action proposals close the loop.
The team hinted at fine-tuning despite strong zero-shot results. When would you actually do it? When the zero-shot curve plateaus below a service requirement on a high-value task, or when you add new vocabulary, e.g. genomics, that isn't represented in pre-training, a small supervised head or LoRa-style fine-tune can yield big gains cheaply.
Also for localization, documentation styles vary by system. A light fine-tune can adapt to local coding, ordering, and lab panel practices. Think of it as domain adaptation.
But lock a fine-tuned governance process, pre-post metrics, fairness deltas, calibration curves, and a rollback plan. Fine-tuning is where well-intended teams can drift from robust to brittle.
Let's wrap with a forward look. What's the next 12-24 months in this space?
Time to event native evaluations, counterfactual-aware fine-tunes, and expansion into additional structured modalities, vitals, meds administrations, immunizations, cancer staging. Clinically, more specialties will see serious pilots beyond cardiometabolic diseases.
Architecturally, longer context with retrieval, continuous numeric tokenization, and potentially mixture of experts for specialty tokens, maintaining compute efficiency while increasing expressivity.
From systems, standardized token pipelines across institutions, event-level lineage, and reference retrieval corpora, these will make models portable and auditable. Also, test-time compute scheduling integrated with hospital ops.
Governance will mature. Model registries, auditable service classes, bias monitoring as a routine dashboard, and guidelines from consortia on safe deployment. Also, better evaluation of impact parity to ensure benefits are equitably distributed.
Strategically, we'll see one engine, many services. A single event model driving risk registries, order set recommendations, bed planning forecasts, and research feasibility scans. The organizations that integrate it into operational rhythms, like a digital twin of patient flow, will outpace those treating it as a point solution.
Final heuristics for our listeners. Give me one each.
Trajectories before snapshots. If your tool doesn't reason over time, it's not thinking clinically.
Compute where it counts. Balance training scale with test time ensembles aligned to your latency and precision needs.
Design for handoffs. Models don't create value. Operational pathways do.
Trust is monitored, not declared. Deploy with live calibration and fairness boards, or don't deploy at all.
Model the clock. Time tokens, censoring, and retrieval are first-class citizens in healthcare. Treat them that way.
That's a wrap. Generative medical event models are moving from research to real-world engines. And as we heard, the secret isn't just more parameters. It's better time, better tokens, and better orchestration. Thanks to our panel and to you for listening. As we land the plane, let me stitch the threads together. Today we saw a generative, decoder-only transformer trained on 151B tokens of structured medical events act like a patient weather model, using ensembles of simulated futures to produce calibrated, time-aware probabilities for diagnoses, outcomes, and operations. And we explored how scaling laws, token design, and test-time compute turn that into a dependable engine for clinical and business value. Technically, the highlights are crisp. Compute optimal scaling via isoflops with alpha and beta around 0.51 means parameters and tokens should scale in lockstep. A roughly 1,000 to 1 token to parameter ratio is sweet spot for medical events. Time tokens and sensoring-aware aggregation translate generations into probabilities and time-to-event forecasts. Quantile tokenization stabilizes lab modeling but invites a next step to continuous numeric heads. And, crucially, performance improves not just with model scale but also with test time ensemble size, especially for low-prevalence tasks.
The business through line is one engine, many services. Launch system-wide risk registries for acute on chronic conditions to reduce avoidable ED visits. Couple LOS and 30-day readmission prediction to orchestrate discharge and transitional care. Use encounter forecasting to smooth clinic capacity and staffing. Then layer specialty adapters only where the zero-shot model underdelivers. This shrinks your model zoo, simplifies governance, and concentrates change management where it moves the needle.
Governance essentials can be summarized as calibrate, stratify, and monitor, require local replication of the loss-to-outcome linkage before go-live, publish service classes with simulation counts and SLOs, log retrieval decisions and surface exemplar trajectories for explainability, maintain fairness dashboards beyond AUC into calibration and impact parity, define rollback triggers when drift or subgroup gaps cross thresholds. Trust is monitored, not declared.
From an engineering stance, prioritize model the clock, extend context or add retrieval for long histories, use hybrid discrete plus continuous outputs for numerics, schedule test time compute, short ensembles for bedside latency, long ensembles for nightly registries, cache stable cohorts, and invest heavily in UX so probabilistic timelines surface as next best actions, order set suggestions, and staffing queues. Interface friction, not accuracy, is the hidden bottleneck.
Clinically, the wins are where time-aware reasoning meets workflow. Ranked, quantitative differentials for hepatobiliary and rheumatology pathways weeks before label. Encounter-level predictions that curate likely labs and procedures without recycling old noise, and calibrated utilization forecasts that make bed meetings and care management huddles less reactive. If you want a North Star metric, watch Precision at K for outreach lists and time to next right test for diagnostic pathways.
Key innovations worth remembering: autoregressive event simulation with time tokens and sensoring-aware aggregation, compute optimal scaling that predicts training plans before you spend, token vocabularies grounded in ICD ATC LOINC hierarchies to learn structure efficiently, and the finding that lower pre-training loss maps to better clinical AUCs in tidy sigmoids, evidence that scale here isn't vanity, it's utility. The near-term roadmap writes itself: longer context plus retrieval, continuous numeric tokenization, counterfactual-aware fine-tunes or uplift heads for what-if decisions, and survival-native evaluation to match the model's temporal outputs, technically incremental, strategically transformative.
Put it to work with a phased playbook. Start with population registries and discharge orchestration, publish performance and fairness dashboards, then graduate to specialty adapters and counterfactuals where the service line demands it. Measure outcomes in operational terms, board time, precision at K, time to workup, so the value story survives outside the data science lab.
To borrow a line from Deming, "In God we trust, all others must bring data." These models bring trajectories, not just data points, and when paired with disciplined governance and workflow design, they convert uncertainty into action. That's our show. Thanks to our panel and to you for joining AI on AI. Until next time, keep scaling wisely and, well, keep modeling the clock.